Anticoagulation versus antiplatelets. These are really important terms that we need to understand that we have a strong foundation on so we can understand how the medications work. So the key differences between antiplatelets and anticoagulation is that antiplatelets block platelet plug formation, while anticoagulants interfere with the extrinsic and intrinsic pathways of creating that plug. Antiplatelets and anticoagulants are drugs involved in the process of blood clotting, but antiplatelet drugs interfere with platelet activation and aggregation, and anticoagulant drugs interfere with the coagulation cascade. So let's review how a clot is made. So what is a thrombus? A thrombus is a clot of blood when blood is thick. Clots, this is a natural healing process, and it's not always bad because we want our blood to clot and stop the bleeding. However, in some conditions, we don't want our blood to clot that easily because we have a risk of throwing a thrombus, getting like a DVT or a PE. So what happens? We have an injury at a site. We activate the clotting factors to form a clot. So an injury happens, the clotting factors are turned on, they know that they have to form a clot. So platelets are going to go to the site right away, and then thrombin activates fibrinogen, and fibrinogen makes fibrin. The blood vessels contract to stop the blood loss, platelet clot is formed, and the fibrin holds all of the platelets there together. So it's important to know these different pieces of how a clot is formed when we talk about the anticoagulant and antiplatelet medications. Let's review what thrombin does. Thrombin's role as an anticoagulant is mediated through binding to a thrombomodulin, a receptor protein, on the endothelial membranes of the blood vessel. So once this is activated, it starts a ton of series of reactions. Now, thrombin has a property enabling it to exert its effect on inflammation and vascular injury. So there's a slide over here on the left you can look at. But when thrombin is activated, there is a link between vascular injury, coagulation, and platelet activation. So thrombin is that link, okay? So something happens, there's a wound, there's an injury, and thrombin goes to that area because thrombin is a link between that vascular injury and how the blood clots and stops from bleeding out. Thrombin receptor antagonism. So thrombin activates platelets and smooth muscle cells by proteolytic activation of cell surface protease activated receptor 1, or we call this PAR1, and this is known as the thrombin receptor. So you need to remember PAR1, okay? It's the thrombin receptor. So thrombin is the most potent activator of human platelets, and a thrombin receptor antagonist is likely to exert potent antithrombotic effects in platelet-rich arterial thrombosis, okay? So thrombin is the most potent activator of human platelets. So thrombin is what comes to the scene first. And a thrombin receptor antagonist, remember our antagonist, is likely to exert potent antithrombotic effects in a thrombosis. So as thrombin receptor antagonism does not inhibit the ability of thrombin to generate fibrin, such an agent is likely to have less bleeding liability than conventional anticoagulants. So PAR1 antagonists, remember protease activated receptor antagonists have an antiplatelet effect by inhibiting thrombin-related platelet aggregation. Thrombin cellular effects are mediated by PARs. Therefore, the activation of a PAR1 antagonist is going to alter signaling in platelets and interferes with platelet activation. So if you learn these drugs by understanding what they are and how they work, it'll be really easy for you to understand this in the clinical practice and as well as for your NCLEX. So some medications that are PAR1 antagonists, platelet aggregation inhibit protease activator, receptor 1 or PAR1 antagonist. So this is an example of a medication, Vorapaxar. It's in this class of medications called a PAR1 antagonist, and it works by preventing platelets from collecting and forming clots that, as we know, can be the cause of a heart attack or stroke for some patients. So just know that Vorapaxar is a PAR1 antagonist, and we're talking about preventing platelets from forming a clot. Next, we have the factor 10A inhibitors. So factor 10A XA inhibitors are a type of anticoagulants that work by selectively and reversibly blocking the activity of a clotting factor and prevention of clot formation. So with these medications, the factor 10A inhibitors, they work within the blood and also within a pre-existing clot, but they do not affect platelet aggregation. This is working on the different part of the clotting cascade. So it's not going to work on the platelet factors like the PAR1 antagonists were. Now we're just looking at the factor 10A within the blood and within a pre-existing clot to decrease clot formation. So our factor 10A inhibitors are used to prevent formation of blood clots. Rivaroxaban, it's a hard one to say, Rivaroxaban, and apixaban. These are common ones that you're going to see. These are factor 10A inhibitors. So this is like Eliquis. So we give these to patients to prevent DVTs, stroke, and pulmonary emboli. They selectively inhibit factor 10A to stop the coagulation cascade. So for these medications, for Rivaroxaban, what you can think of is like, think of a river, think of blood flowing down the river, to kind of think of that, so you can get that name in your mind. So when you see that medication, you'll understand it's a factor 10A inhibitor. Now, of course, some side effects with our blood clotting inhibitors would be bleeding. Also for like Eliquis, we need to monitor liver enzymes. And of course, we have to educate our patients that we shouldn't just stop abruptly taking these medications because we don't want to put them at risk for developing a thrombus. So Xarelto is the brand name for Rivaroxaban. So just remember that, Xarelto, Eliquis. These are factor 10A inhibitors. We're going to decrease the anticipation of our patients developing clots, and they also may be called direct oral anticoagulants or DOACs because we give them orally. And again, an anticoagulant, Rivaroxaban, we're going to think of a river, blood flowing down a river, so our blood stays clot free. So now we're going to talk about antiplatelets. We talked about anticoagulants with our PAR1 antagonists and our factor 10A inhibitors. Now we're moving on to antiplatelets. Clopidogrel is a medication that you'll probably see a lot in clinical practice, but we give antiplatelets to prevent, of course, MIs or stroke with acute coronary syndrome. This inhibits platelet aggregation. So for clopidogrel, you can think of a horse clopping on the platelets, stopping those platelets from coming together and forming that clot. So again, our side effects for thinking of antiplatelets, our patients are going to bleed more freely. So we're always worried about bleeding, hypotension, dysrhythmias, GI upset, and rash are common side effects of antiplatelet medications. So let's review prothrombin and thrombin. So prothrombin is a protein and is produced in the liver, and it is converted into thrombin during bleeding and any subsequent clotting. So thrombin is an enzyme in the blood that facilitates blood clotting by converting fibrinogen to fibrin. So thrombin is in the blood and it facilitates clotting because it turns fibrinogen into fibrin. Prothrombin is transformed into thrombin by a clotting factor known as factor 10. And thrombin then acts to transform fibrinogen, also present in plasma, into fibrin. So this is why you need to know about the factor 10 and the thrombin and the prothrombin and blood clots and how they all work together and how the medications are worked to stop these blood clots from forming in our patients. So we have some other different blood clotting medications or anticoagulation medications, and these are thrombin inhibitors. So argatroban and dabigatran are used to treat DVTs and PEs, and they're used to prevent strokes, and they block the thrombin receptors, and then this stops activation of clotting factors. So of course, again, our side effects are going to be bleeding, GI upset, and possible hypotension. So these medications, they are direct thrombin inhibitors, and they inhibit thrombin from converting fibrinogen to fibrin. Dabigatran is given orally, and their capsules should always be kept in the original packaging because we need to prevent moisture contamination for this medication. So remember that. Next, we have the GP2B/3A inhibitors, and these are great. They're antiplatelet agents, and they prevent platelets from functioning to aggregate and form clots. So they're great at preventing clots from being formed during coronary artery stenting and for treating acute coronary syndromes like MIs or unstable angina. Again, we need to keep a close eye on the CBCs to look for any bleeding, and what they do is that they block the binding of fibrinogen to the platelet. So they make the platelets less sticky, so that the clots really can't stick together. So aspirin, as you recall from our hypertension and MI lecture, we talked about Mona being given during an acute MI. So the A is for aspirin. So aspirin is actually an NSAID. It's a non-steroidal anti-inflammatory drug, but it also has the effects, it inhibits the COX-1 enzyme, which leads to reduced blood clotting. So this is why it's given during an acute MI, and we also give a low dose, or is sometimes known as a baby aspirin, to prevent blood clots and reduce the risk of stroke and myocardial infarctions. And it can also be used to prevent reocclusion of coronary arteries after stent placement. So just know that we don't give aspirin to children because of the risk of Rey syndrome, and we don't take aspirin with alcohol. And if people use aspirin for a long time, they can develop GI ulcers and bleeding, and some it can have acute toxicity. So if your patient's on aspirin and they are complaining of ringing in the ears or tinnitus, we need to notify the provider immediately because this can be an acute toxicity of aspirin. Warfarin is a medication you'll probably see a lot in your clinical practice and in your clinical rotations. So it is an anticoagulant, and it's to prevent the formation of DVTs or pulmonary emboli, or MIs or strokes in patients who have a high risk factor for developing blood clots. And of course, with any of these medications, we want to look for uncontrolled bleeding. So with warfarin, we need to always monitor the PT and INR levels. So a therapeutic INR level for a patient on warfarin is between 2 and 3. And we're not going to give this during pregnancy. And of course, we need to educate our patients who are taking warfarin not to take excessive amounts of leafy greens or other foods high in vitamin K, because vitamin K is the antidote for warfarin. So we don't want the effects to be reversed by having these green leafy vegetables or any other foods high in vitamin K. And if we need to give vitamin K to reverse the effects of warfarin, it needs to be given as an injection or through an IV. Heparin is another anticoagulant that you are probably familiar with, and its purpose is to prevent blood clots. And of course, again, we use this in DVTs or PEs or heart attacks or strokes, but it is a high alert medication because of its high risk of bleeding. So for heparin, we need to monitor PTT levels, And these PTT levels should be between 1.5 and 2 times the patient's baseline. So if the patient's PTT level is more than double the baseline, we're not going to give the heparin and alert the provider. It's also known to cause heparin-induced thrombocytopenia or low platelet levels. So we need to keep an eye on those lab values. And the antidote of heparin is protamine, which is given via IV in case where the effects of heparin need to be reversed. So with heparin, we're going to monitor the PTT, and it should be 2 times the baseline. We also give what's known as low molecular weight heparins, and these are derivatives of heparins, and they're used to prevent blood clots, usually in post-surgical patients who are at risk for developing DVTs because they have limited mobility. The low molecular weight heparins are considered safer than the normal or unfractionated heparins, although potential side effects include a lowered platelet count or thrombocytopenia, as well as bleeding. So these inactivate factor 10A, but unlike heparin, they're less likely to inactivate thrombin, or factor 2. Again, with this one, we need to monitor the PTT, and steady therapeutic levels are reached at recommended doses. So we need to educate our patients that they need to go in and get those lab tests as often as prescribed. And the antidote for low molecular weight heparins is protamine sulfate. So just to review, we talked about the factor 10A inhibitors. They're a group of drugs because of their endings, the XABAN endings, and they're blood thinners. And so, of course, we're going to use them for forming clots. Again, for DVTs, PE, or AFib, they do have the increased side effect risk of bleeding. And we don't really need to monitor the PT, PTT, and INR that closely because they reach therapeutic levels at recommended doses. And then finally, we have our clot busters, or tissue plasminogen activator, or TPA for short. It's a clot busting protein that is also formulated as the name ends in teplase, like atoplase. TPA works to dissolve clots, and it's used to treat medical emergencies caused by clots that block blood flow, such as an acute heart attack or stroke or PE, and even DVTs. So it's given in the setting of an ischemic stroke, and it is important to administer the drug within 4.5 hours from the start of the stroke symptoms. So beyond that point in time, the dangers of giving TPA outweigh the potential benefits. And one dangerous side effect is to note, of course, is the increased risk for bleeding. So again, this is very time limited. For the fullest effect, you must administer within 4.5 hours from the onset of symptoms.